Hello and welcome to my channel. Today we are going to talk about the upper limb vessels. First of all, we have the subclavian artery. We will talk about its anatomy and its course. On the right side, the subclavian artery originates from the brachiocephalic trunk, but on the left side, it directly originates from the arch of aorta. Let me explain this with a diagram. For example, this is the arch of aorta. On the right side, we will have the brachiocephalic trunk. On the left side, we will have the left common carotid and left subclavian artery. From this brachiocephalic trunk, this will arise the right-sided subclavian artery and the right-sided common carotid artery. So this will be the right common carotid. This will be the right-sided subclavian artery. This would be the left common carotid, and this would be the left subclavian artery. In terms of its course, the subclavian artery moves laterally towards the axilla and passes the relationship to the anterior scalene muscle. Now, anterior scalene muscle is going to divide subclavian artery into three parts: first, second, and the third. So, for example, this is subclavian artery. Now, this anterior scalene muscle will divide the subclavian artery into three parts. The first part will be from the origin till the medial border of anterior scalene. This will be the first part. The second part will be posterior to the anterior scalene, and third part will be from the lateral border of anterior scalene till the lateral border of the first rib. Now, the first part of the subclavian artery gives three branches: the vertebral artery, the internal thoracic artery, and the transverse cervical artery. Second part of the subclavian artery gives the posterior cervical artery, and the third part is going to give the dorsal scapular artery. So the mnemonic for this would be the vitamin C, D. So first, as I have explained that from the lateral border of the first rib, subclavian artery will become the axillary artery, marking the start of the supply of the upper limb. So axillary artery lies deep to the pectoralis minor muscle. So the muscle that was dividing the subclavian artery is anterior scalene muscle. Axillary artery is divided by the pectoralis minor muscle. So I will explain this with a diagram. So for example, this is the axillary artery. Pectoralis minor muscle will divide it into three parts. The first part is second part and the third part. And this is between the lateral border of the first rib and the lower border of teres major muscle. So these are the boundaries of the landmarks for dividing the axillary artery. So the first part of axillary artery is going to give one branch, second is going to give two branches, and the third is going to give three branches, which I will explain in a table right now. So the first part will be proximal to the pectoralis minor, second part will be posterior to pectoralis minor, and the third part will be distal. Now there is an important concept that along with the axillary artery, there are three cords of the brachial plexus. One is present laterally, one is present medially, and third one is present posteriorly. And all of this is enclosed within an axillary sheath. So by any means, if there is a compression over this area, then not only the axillary artery will be at risk, but also these cords will be compressed and there will be paresthesia. So this will be discussed later on in the clinical correlate of the axillary artery. So the first part of the axillary artery gives superior thoracic artery. The second part gives thoracoacromial artery. The second part gives second branch as the lateral thoracic artery. Third part of axillary artery is going to give subscapular artery, anterior and posterior circumflex humeral artery. Anterior and posterior circumflex humeral artery are related with the anastomoses around the surgical net of the humerus, and there is axillary nerve that is present along with them in this area. So if there is damage to the blood supply, there is likely to be damage to the axillary nerve at the surgical neck of humerus. So in this case, the risk of damage to the this pathology can occur when there is a proximal humerus fracture. In proximal humerus fracture, surgical neck will be damaged and the vasculature and the nerve supply will be affected. So as I already explained that the lower border of teres major defines the end point of axillary artery and starting point of the brachial artery. So the clinical relevance is that in the axillary artery aneurysm, first of all, we will define aneurysm. An aneurysm is the dilatation of the axillary artery more than twice of its size. So for example, this is a vessel. If it dilates more than 2 cm of its diameter, then definitely it will be compressing the surrounding structures. Although it is rare, but it is going to compress the vasculature. And what type of complications can occur? We can have paresthesia. I have already explained that this axillary artery is surrounded by the cords of the brachial plexus. So they will be affected as well. Followed by muscular weakness in the upper limb. In terms of its treatment, the definitive management is surgical. However, procedures like excision of the aneurysm and deconstructions with the vascular graft can be carried out by a vascular surgeon. So now we will talk about the brachial artery, which is present in the upper arm. It is a continuation of the axillary artery beyond the lower border of teres major. It is the main arterial supply of the upper arm. So its first main branch is the profunda brachiae, which it gives off as it passes down the teres major. It travels with a radial nerve in the radial group of the humerus. So on the posterior aspect of the humerus, there is a radial groove. From this radial groove on the posterior aspect, we have two important structures which passes. Number one would be the profunda brachiae artery, and number two we have the radial nerve. So if by any chance there is a fracture involving this area of the humeral shaft, then profunda brachiae artery and radial nerve both will get damaged. So it supplies the posterior compartment of the arm and it is involved in making the anastomosis around the elbow joint. Then the brachial artery proper, it descends medially in the anterior compartment and it passes through the cubital fossa beneath the basipital aponeurosis. It terminates in the cubital fossa at the neck of the radius. So brachial artery will divide into radial and ulnar artery at the neck of the radius in the cubital fossa. So the clinical point over here is that the brachial artery is vulnerable to humeral shaft fractures. So the clinical relevance over here that is worth mentioning is that laceration or occlusion of the brachial artery can have grave consequences on the musculature in such a way that the arm has a rich anastomotic supply, and complete or partial occlusion or laceration of the brachial artery will result into severe ischemia to the muscles. The muscles will eventually undergo necrosis, and the specific muscles which are affected are the forearm muscles of the upper lip. Now what happens in the muscles is that they get replaced by the fibrous tissue, and the fibrous tissue results into their shortening and leading to permanent flexure deformity. And there is a specific name for this pathology known as the Volkmann ischemic contracture or the VIC. So what it results clinically is there will be fixed flexion of the wrist, fingers and thumb. So now we have radial and ulnar artery. Both arteries arise from the bifurcation of the brachial artery within the cubital fossa, as I have already explained. Radial artery supplies the posterolateral forearm. It is involved in the anastomoses around the elbow and it contributes to the purple arterial network, which we will discuss in a while. Now, the clinical note regarding the radial artery is that radial pulse is palpable in the distal forearm, but the very important landmark for that is it is lateral to the flexor carpi radialis tendon. The second important artery is the ulnar artery. Ulnar artery supplies the anteromedial forearm. It has two very important branches, the anterior anterosseous artery and the posterior anterosseous artery, which supplies the deep flexors and the extensors of the forearm. It also contributes to the anastomotic network around the elbow joint, and it is also involved in making the palmar arterial arches. So, in terms of the hand, we have two important structures, the superficial palmar arch and the deep palmar arch. Superficial palmar arch is formed mainly by the ulnar artery and the deep palmar arch is formed by the radial artery. These two are very important to remember. So the general function of this dense network of two arches is that it supplies extensive anastomotic supply from both the vessels within all the muscles of the hand, and it results into proper functioning of the hand. Even when the hand is compressed or there is strong grip, this rich network will result into extensive blood supply reaching the different muscles present in the hand. So how does ulnar artery and radial artery contribute to these? So first of all, ulnar artery enters the hand anterior to the flexor retinaculum and it is lateral to the ulnar nerve. So now we will talk about the ulnar artery entering the hand. So for example, this is the flexor retinaculum. Here we have the ulnar artery. Ulnar artery is superficially passing over the flexor retinaculum and it lies lateral to the ulnar nerve. Regarding the radial artery, it enters the hand dorsally from the anatomical snub box and it travels medially between the two heads of the adductor pollicis. So these important landmarks of muscles are very important because they can be asked in multiple MCQs. So it supplies the thumb and the lateral index finger and it contributes to the superficial palmar arch. However, the main contribution from the ulnar artery is to the superficial arch, whereas the radial artery primarily contributes to the deep palmar arch. We will discuss this with a diagram in the next slide.